a highly respected expert in the obstetric and gynecological field, Dr. Essam Rashad. He talked about practical assessment of primary amenorrhea. طبعا يا دكتور عصام انا شهادتي في حضرتك مجروحه. احنا مستنيين النهارده نسمع احسن الجديد. تمام. حضرتك بسم الله ما شاء الله قيمه وقامه في الكلينيكال براكتس اند ريسيرش. مستنيين نعرف الجديد من حضرتك. اتفضل يا دكتور.
بسم الله الرحمن الرحيم. شكرا يا صفا على التقدمه الجميله، كتر الف خيرك. I'd like to thank Professor Lubna Touni, Professor Salah Hargoon, my professors for the kind invitation, and thank you for being here today despite the expected harsh weather. So thank you for coming. So my talk is on amenorrhea practical assessment. So being asked to talk about a complex topic like amenorrhea in 15 minutes, just like being asked to put the genie in the lamp. That's really a difficult job, but I'm going to do my best. So what does amenorrhea mean? Amenorrhea is a Latin word meaning A is absence, meaning monthly, and rhea means flow. So amenorrhea means absence of monthly flow. So by definition, it is the absence of menses until the age of 14 if there are no other secondary sexual characteristics developing, or it's the absence of menses by the age of 16 regardless of whether there are secondary sexual characteristics or not. For the secondary amenorrhea, it is the absence of menses of a time equivalent for the length of 3 successive cycles or a period of 6 months. So if you had no menses before, if you are a young girl and you came to the age of 14 without menses, without any secondary sexual characteristic development like the breast, for example, then that's an indication to start investigation. And if you are a girl at the age of 16, regardless of whether you have second sexual characteristics or not, that's delayed puberty, and we need to look into the cause. If you are already a menstruating woman and then the menses stopped for 6 months, this is secondary amenorrhea or equivalent to the length of 3 cycles. I'd like to attract your attention. There is puberty is a complex event. It's not just menses. Menses is a late factor or a late phenomenon in puberty. Puberty consists of thelarche, which is development of the breast, adrenarche, which is development of the pubic and axillary hairs, accelerated growth spurt, and finally the menses. Puberty takes around 4 to 5 years as a whole process, with those different components integrating or interdigitating with each other. Usually it proceeds with the development, or it starts with the development of thelarche, and within 2.5 to 3 years, menarche usually starts. This is a study or a table summary of the normal pubertal development in different populations, and I'm just interested to see those about Egypt. They studied 1,500 young girls, and as you can see, they found the mean age at menarche to be 12.4. This is preceded by proparche and thelarche. So again, the normal puberty is different events with menarche coming nearly at the end. If you have some of those events already developing, like the thelarche, like the thelarche or the breast, and adrenarche or puparche, which is the axillary and pubic hair, so the axis is starting, so you can wait a little bit for the development of the menses. But if you come to the age of 14 and nothing at all has developed, that's definitely abnormal. So this is about the normal pubertal development. So to think about amenorrhea, to think why a girl came to the age of 14 without menses or to the age of 16 without menses, you need to think in a compartment-like fashion. You need to think about the different compartments and which one is at fault, which one is pathological. So what are those compartments? Starting from below upward, we have the uterus. We need to have a uterus with a functioning endometrium inside. with a functioning endometrium inside, and very importantly, a patent outflow tract that can allow escape of the menstrual blood. Then that's functioning, that's working fine. Then above it, we need to have the ovary, which is producing steroids, estrogen, progesterone, which are working on the uterus to do the job. Good, then that's functioning or that's not functioning. Then we need to have a pituitary and hypothalamus, which through the GnRH hormone and through the gonadotrophins, FSH and LH, are working on the ovary to produce the gonadotrophins to work on the uterus. Okay, and then above the hypothalamus is the central nervous system, which is relaying different environmental cues and stimuli and transmitting them to the hypothalamus to start working. So this is the axis, the HPO uterus axis we are working on. So we need to think if a woman is, or a girl is amenorrheic, is the cause, or does the cause lie in the uterus and the outflow tract, or is in the ovary, or is in the pituitary, or it is in the hypothalamus. So here are compartmental hierarchy that we are using this model to think where is the cause or where lies the cause. So again, sticking to the title because time is running, practical assessment. What do we need to ask a girl or a woman with amenorrhea with? First, don't think much of differentiating primary from secondary amenorrhea. That's not really productive, and it may lead to missing some important causes. We look at amenorrhea as amenorrhea. Yes, some causes are known to present with primary amenorrhea, like if you have a congenital cause, for example, it definitely would present with a primary amenorrhea. But generally, we think of amenorrhea as amenorrhea without paying much attention to primary or secondary amenorrhea, right? Because some causes present commonly with primary, but sometimes with secondary. Others are commonly with second, sometimes with primary, and so on. So we think of amenorrhea as one thing. So people jump to investigations. Let's measure the FSH. Let's measure the estrogen. Let's do the ultrasound. Let's do the MRI. But there are, again, medicine, and we have learned that very much in the Department of Medicine. That's you who have taught us, start with history, and then move to the physical examination, and finally you move to the investigation. So this is the golden rule that I've learned when I was a student, and Professor Lobna was teaching me by this time, by the way. Dr. Salah was still a مدرس مساعد. تمام. Dr. Muhammad Abdurrahman was assistant lecturer as well. So those people did us a great favor in teaching us this. So يعني إذا كان دكتور لبنى سمعت تقول after 30 years, we are coming again to say the same things that they have taught us. Start with the history. So, يعني هم كانوا 30 دكتور لبنى. Is that okay? بس كورونا كانت لسه مدرس يعني لسه كانت لسه مدرس. So start with the history. This is what we have learned from you. So there are important things that you can reach a diagnosis just by listening to the patient. First, the cyclic pelvic or lower abdominal pain or urinary complaints. A young girl who has monthly abdominal pain and she's amenorrheic. Monthly abdominal pain, but nothing is coming out of the vagina. This is mostly the obstructive Mullerian anomaly or imperfect hymen. And this is common. We see this a lot. A young girl at the age of 14 or 15, and she presenting with amenorrhea, but monthly she has the abdominal pain, and her mother says, we expect her to have menses every month, but nothing happens. It's mostly imperfect hymen. This is mostly imperfect hymen. Or other obstructive anomalies like the transverse vaginal septum or cervical. This is a history point. Another point, amenorrhea following endometrial curettage or uterine surgery. That's important. This usually refers to, and this is usually a secondary amenorrhea. This usually refers to destruction of the functioning endometrium. This is what we call the Asherman syndrome or the intrauterine synechia. So if you have a woman presenting with secondary amenorrhea after uterine surgery, think of the Asherman syndrome. This comes on the priority of the list. Amenorrhea with hyperandrogenic features. You know that, of course. Amenorrhea with hirsutism, acne. Think of the PCOS. Think of the PCOS, of course. Amenorrhea with galactorrhea. She's complaining of some secretory products coming off the breast. And to be galactorrhea, they need to be bilateral and to be coming from different or multiple orifices. Amenorrhea with breast secretion, this is hyperprolactinemia. You can just come to this diagnosis just by listening to the patient. Other history points. Yes, a woman who is starting to have menstrual irregularities, they're becoming infrequent, and then they stop. Probably this is what we call premature ovarian insufficiency, or premature, in the past they called it premature ovarian failure, but now they call it premature ovarian insufficiency. Okay, so she's like a menopausal woman, but this happened early. Those things that play with the CNS, head trauma, severe physical or emotional stress, weight loss, intense exercise, these all transmit to the hypothalamic amenorrhea. Vaginal dryness and hot flushes, again the premature ovarian insufficiency. Progressive hirsutism or virilization, severe hirsutism, this is not just a PCOS. PCOS is often a cause for mild hyperandrogenemia, but if you have severe hyperandrogenemia, think of a tumor, an androgen-producing tumor. So again, these are just history points that can attract our attention to the cause. Then we come to the physical examination, our logical next step. Weight loss. If the patient suffers significant weight loss, think of an eating disorder or hypothalamic amenorrhea. Again, if she is obese, think of PCOS. If she has short stature with infantile sexual characteristics, think of gonadal dysgenesis, and the most clear example is Turner syndrome. Then look at manifestations of hypo and hyperthyroidism, and they are the experts on that. If they have warm, moist skin, rapid pulse, tremors, exophthalmos, this is hyperthyroidism. Dry, scaly skin, cold, thinning of scalp, hair, and eyebrows, this is hypothyroidism. Thyroid abnormalities can result in amenorrhea. So you can have the clinical manifestations of thyroid dysfunction. Acanthothosis nigricans, which goes with insulin resistance and PCOS. So again here, what I want to attract your attention to is take your time doing a physical examination. You can have clues just before doing any type of investigation. Other points in the physical examination, the hyperandrogenic manifestations with the PCOS, the severe virilization with the androgen secreting tumors. Then you move to the breast. The breast, you have to do the Tanner classification. And this is to indicate if she has endogenous estrogen or not. If the woman has a breast that is less than the stage for her age, this probably means she does not have endogenous estrogen. And you can know this even before asking for the bioassay. And I'm going to, or asking for the lab assessment. And I'm going to tell you that the lab assessment, there are fallacies. And there are labs who cannot do the right estimate or the right measurement. So here, just having a breast which is underdeveloped is a warning sign. Again, other signs, they all can be transmitted to different causes of the amenorrhea. So start with history, start with examination. There are several things that you can pick up with the history and examination alone. Again, being practical, so I thought the best way is to put things in algorithm. Okay, so back to our hierarchy. You remember that the first thing we mentioned is the uterus and the patent outflow tract. Outflow tract is easy to examine because it's the vagina and the cervix. You can examine them clinically. Even if this is a virgin, you can use what we call a vaginoscope, which can be introduced inside the hymen, and you can see inside. So they have adequate vagina and good cervix, so the outflow is patent, the outflow is correct. Alternatively, you find what we call blind vagina. So if you examine the vagina, it's adequate in length with a normal cervix. This is a normal outflow tract. Move to the next level. If you examine it and you find blind vagina, then move to or think what causes the blind vagina. If the blind vagina is associated with symptoms, then think of the imperforate hymen. Imperforate hymen is very easy. This is a clinical diagnosis. You can diagnose her on table. The girl just has a bluish bulging hymen which bulges further with valsalva. So imperforate hymen is a very easy thing. She is amenorrheic. She comes with a cyclic monthly abdominal pain, and then you examine her vag or her vulva. You find the hymen bulging, and it is bluish, and it bulges more with valsalva. This is very, very simple. the imperfect hymen or the transverse vaginal septum, which are nearly the same thing, but with a different level. But the blind vagina comes in two things, the Mullerian agenesis and the androgen insensitivity syndrome. So again, we speak on level 1. Level 1 is the uterus and the outflow tract. This is, outflow tract is very easy to examine. You just look into the vagina with a clinical examination, with the cascospiculum, see the vagina and cervix, they are normal. Even if she is virgin, use the vaginoscope, which does not interrupt the hymenal integrity. Normal hymen, they move to the next level. No, I found, or I'm sorry, normal vagina. No, I found a blind vagina. Blind vagina, didn't think of those two things. The Mullerian agenesis and the androgen insensitivity. What is Mullerian agenesis? Mullerian agenesis is a very normal. أحتاج 5 دقايق تاني ممكن؟
Just 5 minutes.
Okay.
Okay.
Okay. فالبلايند فاجينا هنا you will see the Mullerian agenesis is a 46XX female with everything normal developing ovaries, but the uterus does not show up. The uterus and the upper vagina do not develop because of what we call Mullerian agenesis. So everything is normal in her except that she's not having menses and she has no way to get pregnant. She does not have a uterus. And the only way is just to do some plastic surgery to improve the vaginal pouch to allow for sexual intercourse. Androgen sensitivity is the same thing, but this is a 46XY male. He was born as 46XY with tests with androgens but no receptors for the androgen. So the end result is the development of a female-like. So this is a normal phenotypical female but with a blind vagina. And a differentiating point here is of course the karyotyping, and here in the androgen insensitivity very scant or absent pubic hair. It's strange in this case because you find good development of the breast but no pubic or axillary hair, which usually develop together. But in this condition there is a discrepancy with the breasts developing but no pubic and axillary hair. So again, this is the outflow tract and this is what you can come up with. Then we found the outflow tract normal. The outflow tract normal. Then we move to another level. Just before we come to that second level, mind you, a part of the outflow tract is the Asherman syndrome itself. And the Asherman syndrome is intrauterine synecdoche. You find the cervix and vagina normal, but still the uterus itself contains the adhesions. Okay, but this is easy to pick up because it's usually a secondary amenorrhea and it's usually related to surgery or trauma, post-abortal or post-surgical. So if you have a patient with secondary amenorrhea and for developing after surgery, think of inside the uterus. Don't look at the vagina only. Don't look at the outflow tract itself, but look at the uterus itself through a hysteroscope, منظار. Okay, all this is normal. Then think of the other or the higher level, which is the ovary. How is the ovary working? We need just to measure the estrogen. We measure the prolactin TSH, FSH, and endometrial thickness. Endometrial thickness is measured with ultrasound. Endometrial thickness is a bioassay of estrogen. Don't measure it in the lab. The labs make mistakes. But measure it with the ultrasound. If you have good development of the endometrium, there must be inside good estrogen, right? And this will be supported by finding a normal FSH level. Why do we measure the TSH and prolactin? Because the thyroid or the hyperprolactinemia can be the cause. If they are normal, then we leave them alone. If they are abnormal, then we treat them. So the ovary will be normal if it has good level of estrogen measured or normal endometrial thickness or positive progestin challenge. If the ovary is producing estrogen well, then the ovary is fine. The question is if the ovary is not producing adequate estrogen. And these are the cutoff levels. So we measure the FSH only. It will be abnormal if less than 5, abnormally low. It will be abnormal if it is above 20, abnormally high. If the FSH is abnormally high, this means ovarian failure, and there is nothing we can do. This is the end of the story, unfortunately. Right? If it is abnormally low, the FSH, then we think of the higher levels, the hypothalamus or the pituitary. We think of the hypothalamus or the pituitary. So again, we measure TSH, prolactin, E2, and endometrial thickness. Thyroid disorder, treat. Hyperprolactinemia, treat. The ovary is producing normal estrogen production. Then what we are missing is the progesterone, and this is usually PCOS. No, the low estrogen production, then I need to see what is happening. Why is the estrogen or the ovary producing low estrogen? If the ovary is producing low estrogen, it's either the ovary is in problem, so this is ovarian failure with high FSH, or the ovary is normal but the FSH is low, and this is a pituitary hypothalamic cause. So we move again to the higher centers. If we think we have low estrogen production with high FSH, this is ovarian failure. With low FSH, we need to think of the pituitary or the hypothalamus. We can check that with an MRI on the pituitary. If we have a pituitary tumor or a pituitary adenoma, we can treat it. Otherwise, it's a hypothalamic cause. And the hypothalamus, it collects information from different parts of the body. So, as we just mentioned, severe exercise, weight loss, severe stress or mental stress, hyperprolactinemia, hypo or hyperthyroidism, all those things work on the hypothalamus. So if we reach the point of the hypothalamic cause, we may find a cause for the hypothalamic reason, or a primary hypothalamic amenorrhea. And we just treat her as this.
You need another 2 minutes?
Please. Last 2 minutes.
Just 2 minutes.
Last 2 minutes, okay? So again, just as to summarize, think of the different compartments, take the history, take the clinical examination, think of basic investigations. Just all you need to do at this level is to assess the compartment which has the problem. And then every compartment has its own differential diagnosis. If you can just come to the compartment, then you have nearly made 75% of the diagnosis. I just want to attract your attention here to the majority of cases of amenorrhea tend to have identifiable pathology. PCOS, hypothalamic amenorrhea, premature ovarian failure, or hyperprolactinemia. These are by far the most common things. These are by far the most common things that we see if you add to them in impaired for timing as well. Classifying to primary or secondary is not needed. Pregnancy should never be forgotten. Always think of pregnancy as a potential cause, whatever the circumstances, and you need to go in a systemic methodological way, considering the hierarchy, the anatomical hierarchy, just to come to the compartment which is pathological. And thank you very much.
Dr. Essam,